All right, let's dive into contact dermatitis. It's one of those common clinical challenges that can really feel like you're playing detective. And by the end of this, you're going to have all the key clues you need to crack the case. So let's get started.
So, you've got this in front of you. A patient comes in with this red, super itchy, eczematous rash. Your job is to figure out what's causing it. Is it their new laundry detergent? That cheap jewelry they bought? Maybe something they touched out in the yard? This is the central mystery we're trying to solve.
And here's a perfect example. This is that classic textbook picture of poison ivy. You can see those linear vesicles, right? When the plant literally brushes up against the skin, it leaves behind this oily allergen called urushiol. And what you're seeing here is the immune system's response. See how the pattern itself is a massive clue? It tells a story.
Okay, so to even begin our investigation, we have to figure out the first, most fundamental clue. Are we dealing with an allergic reaction, or is the skin just irritated? This is the first fork in the road, and it's an absolutely crucial one.
This really breaks it down. On one hand, you have irritant contact dermatitis. It's actually the more common of the two. Think of it as straight-up direct damage, like a harsh chemical that just strips the skin's protective barrier. But allergic contact dermatitis, that's a whole different ballgame. That's a specific type 4 delayed hypersensitivity reaction. And what that means is the patient's immune system has seen this thing before, gotten sensitized to it, and is now launching a full-on attack.
So if we're leaning towards an allergic reaction, who are the usual culprits? Let's take a look at the lineup of the most common allergens you're going to see over and over again.
And here they are. I mean, look at this list. So many of these are in everyday items. Nickel is everywhere. Jewelry, the buckle on your belt, even your cell phone. Fragrances, don't even get me started. And for those of us in healthcare, check out rubber accelerators. Yep, from the gloves we wear all day. But the one that might surprise you? Neomycin and bacitracin. That's right, the stuff in those popular antibiotic creams.
You are going to hear this from your patients all the time. But doc, I've used this same lotion for 10 years. It can't be that. Well, this quote right here is your answer. Remember, it's a delayed hypersensitivity. It needs that prior sensitization. That means a person can use something for years with no problem, and then one day, boom, their immune system finally decides it's had enough. This is a sight that's probably all too familiar, right? Either on your own hands or a colleague's. This kind of severe hand dermatitis, with all the redness and those painful cracks, it's so common for healthcare workers. And a very frequent cause? You guessed it, the rubber accelerators that are used to make disposable gloves. It's a real occupational hazard.
Okay, here's another one to lock away in your brain. When you see an itchy eczematous rash right around the belly button, your first thought should immediately be belt buckle dermatitis. It is the textbook presentation of a nickel allergy, usually from the metal snap on a pair of jeans or the buckle itself.
So, you've taken a really good history, you've examined the rash, and you've got a few suspects in mind. How do you actually confirm it? You need a definitive test, something that will pinpoint the exact trigger and prove your theory.
And that's where patch testing comes in. It's the gold standard. On the left, you can see how it starts. Tiny amounts of different allergens are put on these patches and stuck to the patient's back. They stay on for about 48 hours. Then, when you take them off, you look for a reaction, like the one on the right. See that red inflamed spot? Bingo, that's our culprit. You found the exact substance that's causing the problem.
Okay, so you've identified the culprit. You've officially cracked the case. So, now what do? The final stage is all about managing the current flare-up and, just as important, preventing it from ever happening again.
The plan here really boils down to 3 very logical steps. Number 1, and this is the big one, is strict avoidance of that allergen. That is the only real cure. Step 2 is to treat the inflammation that's already there, usually with some topical glucocorticoids to calm things down. And finally, step 3 is counseling. You have to empower your patient with the knowledge to read labels and recognize where their triggers might be hiding.
Now, this right here is a fantastic, super high-yield clinical pearl. Remember how neomycin and bacitracin were on our list of common allergens? Well, a reaction to them can look a lot like a worsening wound infection, which can be really confusing. So the key takeaway is this. For simple, clean wounds, just tell your patients to use plain old petrolatum. It helps with healing and doesn't carry that risk of sensitization.
So let's end with this question to keep you thinking. A patient comes in with a lotion that says hypoallergenic right on the bottle, but you suspect it's the cause of their rash. You should know that that term hypoallergenic isn't really regulated. So what are you going to look for in that ingredient list? What common fragrances or preservatives could still be hiding in there? Answering questions like that, well, that's what makes you a really great clinician.